Hi, my name is Francesca Russell. Today is June 6, 2025. I am doing my final presentation for the University of New England's Pathophysiology online course. Today I'm going to speak about bipolar mood disorder and go into all the aspects of it. So starting with the definition, this is a chronic psychiatric reoccurring episodes of mania, hypomania, and depressive states. You're going to see frequent mood swings and this functional impairment. There's also 3 significant types of bipolar. So you're starting with bipolar 1. You're going to see these reoccurring manic episodes that can last greater than or equal to 7 days. These manic episodes might require some hospitalizations as well. And then you're also going to alternate with the depressive states. So that's bipolar 1. And then you have bipolar 2, and this is going to be your hypomanic episodes. These are going to last greater than 4, equal to 4 days. Very rarely will you see any mania, like the mania. It's more so these depressive states. And then you have this cyclothymic, I think that's how you say it, disorder, and this is a milder case of the bipolar, but you're going to see these symptoms last greater than 2 years. So you're still going to have the mood swings. It's just not going to, in these depressive states, but it's just not severe enough to classify them as bipolar 1 or 2. So the etiology of bipolar is it's hereditary and it's linked to multiple genes. It's also could be factors in your neurotransmitters, including your serotonin, your norepinephrine, and your dopamine. And then there's also parts of your brain that change and get affected. So your prefrontal cortex, your amygdala, and then your hippocampus. And then also contributing factors like stressful life events can trigger bipolar to come out. Also substance abuse and sleep disturbances. So not getting enough sleep cannot regulate those neurotransmitters. Going into what kind of syndrome bipolar mood disorder is underneath the mood affective disorders. And there's symptoms that classify these manic episodes. So the manic episodes, you're going to see that these patients are like having this weird, just elevated energy. They just feel like they are on top of the world. They're talking very quickly. They're not getting as much sleep. They're staying up for days at a time. Their self-esteem is very boosted at this time. And it's hard to get these people out of this state. Then you're going to have these depressive states where these people are just constantly fatigued. They're constantly not wanting to do anything. There's no pleasure in activities. Also, lots of suicidal ideation and feeling worthless. So making sure when they're in these depressive states, we're very ensuring that the suicidal ideation is taken care of. Then going into, diagnosing bipolar. So this will be through a psychiatrist's clinical assessment and just exam assessment. So they're going to try to rule out any type of, imbalance hormones that might be causing the mood swings. We also look at some CBC blood work to make sure that the fatigue's not due to like an anemia of some sort. Also ruling out some neuroimaging such as like CTs, MRIs, ensuring that there's no brain tumors or things that could be impairing that cognitive functional impairment. So making sure those are ruled out is huge, but there's no, lab diagnostic that you can be like, oh, you got bipolar. It's due to clinical assessment and physical findings on those rule outs. And it's really hard to differentiate sometimes bipolar 2 versus major depressive disorder. So you're going to see the depressive disorder, you're not going to have any signs of mania. And this is also treated with a monotherapy of antidepressants. So lots of the times if patients that have bipolar are treated with antidepressants, it actually triggers manic episodes. So that would be a way to differentiate if a physician was having trouble differentiating between the major depressive disorder versus bipolar 2. And then, of course, with treating bipolar, there's going to be complications, especially with your bipolar 1 and your lithium. So lithium is a very strong medication, requires lots of doctor visits, follow-up labs. Lithium toxicity can be very life-threatening, causing seizures and cognitive impairments there and permanent damage. So ensuring that you follow up with that. Also, when these patients are in these active depressive states, the suicidal ideation, they're actually 15% higher to die by suicide than the general population. So making sure that they get the help they need. And then, of course, making sure they're maintaining their social relationships, their jobs. All of that can be some complications from bipolar. You'll see them not being able to maintain those relationships because of the frequent mood swings and these states of actively having lots of energy and then not. And then you also see a lot of substance abuse disorder with the bipolar, trying to kind of medicate themselves through it, but it actually triggers more harm. So understanding bipolar is very important, and ensuring that the patients are treated appropriately, and ensuring that we can manage those mood swings as much as possible so that quality of life is preserved. Thank you for listening, and this is the last presentation I'll do. Bye. All my references will be under the caption under AMA format. Thanks.